My name is Andy Limper. I'm a member of the Pulmonary Fibrosis Foundation board, and I've had a variety of roles. Up until last night, I actually was serving on the research review committee that hands out the various grants. And so it is a real pleasure to have the first talk for this session actually be given about the research that was done with support of the Pulmonary Fibrosis Foundation, and it's my pleasure to introduce Dr. Sam Ash from Brigham and Women's Hospital. Sam.
Thank you so much. It's a real pleasure to be here today. And I first just want to say thank you to the Pulmonary Fibrosis Foundation for the support over the last couple of years. Really, this work couldn't have been done without that support. Let's see if I can figure out the advancing here. Let's see. There we go. Great. Very brief disclosure, not related to the current work. And so I think many of you in the room are familiar with this, but I just want to make sure to give a little bit of background. And so for a long time, it's been recognized that there are patients who, on their CT scan, have subtle abnormalities that don't quite meet the diagnostic criteria for interstitial lung disease or IPF. And over the last decade or so, we've sort of settled, or most people have settled on a term for this, and we've been calling it visual interstitial lung abnormalities, or ILA. And you can see the definition here. They're non-dependent changes that affect more than 5% of any lung zone of one of these interstitial features, or combined of these interstitial features. And in some instances, they probably are correspond to smoking-related interstitial fibrosis or respiratory bronchiolitis. And we and others have been interested in how we might be able to detect these things in a more automated fashion with a few goals in mind. One is to potentially be able to screen larger cohorts. As you know, there are several million individuals who are eligible for lung cancer screening in the United States. And if we could potentially be able to screen all those individuals for early interstitial disease, that would be amazing. And then also to be able to measure changes over time. I think we've all had the experience of sitting in clinic and seeing a patient and seeing that they have subtle interstitial changes that are changing, and really trying to get a sense for, is it a real change? Does it reflect an actual quantitative difference? Just a little bit more background on ILA in general. ILA has been associated with increased mortality, has been associated with worse lung function. On the left, you see data from the COPD gene studies showing the association between the visual presence of ILA and mortality. And over the last few years, it's been established that ILA is associated with similar things to what IPF is associated with, albeit in a lesser degree. So associated with a single nucleotide polymorphism in the promoter region of MUC5B, mortality, lung function, decreased exercise capacity, and a shared exposure with smoking. And so as I mentioned, we've set out to try to figure out if there are ways to quantify this. And I'm going to describe to you just one method that we've been working on. There are a number of these, and one of the challenges facing the field is trying to determine which of these methods is most appropriate in which situation. And the method I'm going to tell you about today, which was funded in part by the PFF, what is called a local histogram-based method. I'm not going to go too much into the details of it, but it involves, and I think sort of exemplifies the strength of our group, which is comprised of both pulmonologists and computer scientists. And so my mentor, George Washko, and I have, over the last several years, placed somewhere between 100 and 150,000 training points in a number of research cohorts. And what we do is we open up the CT, we go through the image, and we label areas as being normal tissue, honeycombing, et cetera. And that's what you see on the left side in a patient who has IPF. And then we extract from those areas the histogram of density around those areas, and we compare de novo regions of other CTs to those and classify images as being, as having interstitial features or not. And so this is what you see here on the left side, a sample patient from the COPD gene cohort, and in green you see overlaid areas that are identified by the algorithm as being interstitial. And we've shown, and others have for other techniques, that these approaches are reasonably accurate for the diagnosis of visually identified ILA with AUCs in the neighborhood of 0.8 to 0.9. We've also shown that these features are associated with the same things that ILA is associated with visually. So they're associated with worse lung function. That's what you see on the far left. So that's FVC on the y-axis and quartile of interstitial features along the x-axis. In the center, you see decrements in exercise capacity associated with these interstitial features. And on the far right, you see association between healthcare-related or respiratory-related quality of life and interstitial features. The text might be a little small to read, but again, what you see here is the association between these interstitial features and mortality. And so the more interstitial features you have, the more likely you are to die over the ensuing 10 years. And then this is a little bit of a busy table, but if you just focus on the top right, you'll see the association between these interstitial features and MUC5B. And so what you see is that even when we adjust for other things, the visual presence of interstitial features, et cetera, there is an association between the presence of these interstitial features quantitatively and the MUC5B promoter polymorphism. And so what we've started to sort of think of as we think about these quantitative interstitial features is that what we're potentially detecting is this overlap, this larger group of individuals, this larger group of features, which encompasses, in some cases, visual interstitial lung abnormalities, and that in some individuals who have these features at baseline, they may ultimately develop visual ILA or may already have visual ILA and ultimately develop IPF. And our goal with this is to hopefully try to start to intervene in the disease earlier and identify people who are at risk. And I think of this sometimes as the cardiologists think of high cholesterol or high blood pressure. If we're able to identify people who are at risk for cardiovascular disease, who are at risk for developing ischemic cardiomyopathy and ultimately heart failure earlier, then we can intervene using statins or antihypertensives in order to prevent them from ultimately progressing. And clearly we're a ways away from that with pulmonary fibrosis, but in my mind, that's sort of the ultimate goal, is to be able to intervene much earlier in the disease process. And so these are the potential uses for this type of approach: the early identification of risk I mentioned, the identification of high-risk subgroups, potentially in overlapping diseases, the stratification of risk, and measurement of progression. And I'll walk through each of these just briefly. And so this is what I was mentioning earlier, this idea that maybe we can intervene earlier in the disease process if we can, in an automated way, identify people who have these things. And you could imagine you have a patient who's seeing their primary care provider, they go and they get their lung cancer screening, CT, and it pops up that, oh, by the way, they also, in addition to having a small lung nodule that you might need to get a repeat CT on in 3 months, they also have 2% of their lung occupied by these interstitial features, and maybe the next time they get that CT, we should see if that amount increases. This is the same sort of Kaplan-Meier analysis, now looking at those individuals who don't yet have visual presence of interstitial abnormalities. And what you can see is even in those individuals, even in those people who are going for their lung cancer screening CT, for example, who don't yet have the visual presence of these interstitial abnormalities, the more of these interstitial features you have, the higher your mortality over time. One other potential role for these things is the identification of high-risk subgroups. So we know that there are other respiratory diseases, for example, COPD and emphysema, which share risk factors with IPF and with ILA. And it's possible that using this type of technique, we might be able to identify people in those other diseases who are at high risk. And so these are data, again, from the COPD gene cohort looking at the interaction between interstitial features and emphysema. And on the left, what you see is the interaction between interstitial features and emphysema with regard to diffusing capacity, such that those individuals who have interstitial features have a greater decrement of diffusing capacity for a given amount of emphysema. And on the right, you see all of the people represented in that Kaplan-Meier curve on the right have emphysema, and you can see that those individuals who have both emphysema and interstitial features have higher mortality than those with emphysema alone. Might be able to use this type of approach for risk stratification. So can we look within people who already have these diseases and identify high-risk groups who might be those who we want to follow more closely or potentially intervene upon? On the left, another KM curve showing those individuals who have visually identified ILA and then quantifying how much they have using this technique, and again showing that there's a dose response here. The more interstitial features you have, once you're defined as having ILA, the more likely you are to die. And on the right, just showing that we can use this type of approach to identify specific subgroups. We can identify honeycombing, for example, in an automated fashion and show that those individuals who quantitatively have honeycombing, just as has been seen visually, have a higher mortality among those people with IPF. And then finally, and this is a little bit hot off the presses and should be taken with a grain of salt, the measurement of disease progression. This is a little bit still a work in progress. I'm not going to talk so much about the measurement of progression in IPF. If you're interested, Steve Humphreys, David Lynch, and their group have a very interesting paper in ERJ from last year looking at the use of another type of method in measuring progression in patients with IPF. We'll talk a little bit about the measurement of progression in people who have ILA. Again, this is a little bit preliminary, but on the left you see a repeated measures correlation plot for change in interstitial features and change in FVC over time. And there's not an incredibly strong relationship. This is in a cohort that includes people who have emphysema, who have other diseases, but there is a relationship such that as interstitial features increase over time, lung function goes down over time. And we could have a larger discussion about, should we be measuring each of these, both of these, how do we use them in conjunction, but I think it's interesting that they're associated. And then the other figure that you see here is the association between interstitial progression and mortality. So if we take people who have interstitial features at baseline visually and then look at those people who progress, those people who gain interstitial features over time have a higher mortality over the ensuing 5 years of follow-up. So in conclusion, I think quantitative measurements have a lot of potential. There's a lot more work to be done, specifically around looking at how interventions might modify progression and other factors, but hopefully over the next couple of years we'll continue to work in this area. I want to say a big thank you to the Pulmonary Fibrosis Foundation. Again, this work really could not have been done without your support, and I greatly appreciate it, and also to funding from the NHLBI, from the support that I've received from the CWD Gene Foundation has been hugely important, and then obviously mentors and collaborators, George Washko, Raul San Jose Escobar, David Lynch, Steve Humphreys, and others, and everyone at the Brigham. Thank you.
That was a fantastic talk. We have time for one or two questions. I'll ask, so these patients are challenging in the clinic. We see this little whiff and we don't know what to do. Is the algorithm automated when you do your follow-up scan, or do you have to, cursor around the things? What I'm getting at is, if it's automated, there's roles for AI to ever refine your algorithms.
Right. Yeah, it is automated, and so once the algorithm is trained, it can be deployed easily on repeated scans. There are issues involving progression in terms of thinking about, do you measure overall progression? Do you link scans voxel by voxel and measure progression that way? And so there are definitely problems in measuring progression, but it is a fully automated approach. Fantastic.
We have questions out from the floor. Yeah, go right ahead.
Right. Thank you very much for a fantastic talk. So this morning we talked a bit about senescence. If you hypothesize, or if one hypothesizes that epithelial senescence occurs at a relatively early juncture in the pathogenesis of IPF, then you might surmise that you would see some of it here. And I'm wondering whether or not folks have looked at that. And if that is the case, would this be potentially the ideal context in which to administer an agent, perhaps by the inhalational route, that serves to hinder senescence?
I think it's an excellent question. So one of the groups we work closely with, the Brigham, is Matt Honeyhockey, Rachel Putman, who are sort of interested in this idea of aging and telomere length, et cetera. And we've not specifically looked at that using this approach, but it's something that we've been interested in or hoping to do in the future.
Fantastic. Well, I'd like to congratulate you again on some fantastic research. It's really been super to see the results of what the PFF has put some funds into. So congratulations.